Brilliant, thank you. Mark, as you've done such a lovely introduction for the session today, I will skip to slide 3, if you don't mind, on the screen. So I'm Miriam Doherty and I'm Programme Manager in the Primary Care team at the ICB. I'll hand over to Clive and let him introduce himself.
Oh, hi. Yeah, I'm Clive Newman. I'm the Director of Primary Care for the Integrated Care Board, which means that, me and the team are responsible for commissioning dental services alongside general practice, pharmacy, optometry, etc. Yes, that's me.
Thank you. So I thought I'd start off with this slide today because we use quite a lot of jargon in the NHS and we're very aware of that, and we're, trying to make things as understandable as possible throughout the session. Like Mark said, we will be looking in the chat box, so please feel free to ask questions, and these slides are available, so if you peruse them or share them with people afterwards and any questions come up, then you will have our contact details to get in touch. But just to make, hopefully, the slides run a bit smoother, when we talk about urgent dental treatment, we're talking about things that aren't about routine care. So it's not your general checkups, it's more if you've got a sudden toothache or nagging pain, maybe from an unknown cause or source, or maybe it's a very obvious cracked tooth, cracked filling, causing some discomfort and pain. General access. So when we talk about general access, that's all of the routine care. And we just feel that it's really important that people understand that registering with a dentist is very different to registering with a GP. With a dental practice, they don't have catchment areas as such. So hypothetically, if you were able to travel, you could travel to see a dentist anywhere, as long as they have that availability. So very different to a GP practice. Secondly, it's also important to note that since 2006, dentists don't necessarily maintain lists of NHS patients anymore. So unlike your GP practice, where you register and they keep your records and you are registered at that practice, some dentists may maintain lists of NHS patients to do recalls, but not necessarily. So they don't necessarily keep you on their books as a registered NHS patient once you've gone to visit them. So throughout the slides, we mentioned things called units of dental activity. So what we mean by that is units are basically a way of measuring jobs done by a dentist. So it might be a routine checkup, it might be a level of treatment, so a filling, and then maybe further up could be a crown or extraction. And there are set payments for each sort of unit of treatment. When we talk about procuring services, so what we mean by that is to formally buy services from an external provider. So that's typically through a structured NHS process involving contract negotiations, which we call a procurement process. Okay, I'll hand over to Clive to do our next few slides. Thank you.
Thanks. Yes, as I've introduced myself already, so I won't do that. I will, though, just highlight that we've got a couple of people from the team, as well as myself, who might come in to answer questions if I can't, or correct me if I've got something wrong. So Lisa's here. I think you can see Lisa there, and James, and then Lisa from our team as well. Lisa Wayne is also here. So alongside we and Miriam as well are the team that buy services on your behalf from dental practices. So before I just start on, so what I'm going to do, as we've already said, is I'm going to talk a little bit about what we've done, and then what we're planning to do, and get your view really on what else we might do or how we might improve things. I think this slide is slightly misleading. It's talking about achievement highlights. I think what I don't want to do is diminish the problems we have with dental care. The difficulties that exist, not just here in Derbyshire, but across the board, that are very well known, and rightly so, in terms of patients accessing dental services. So we have 140 or so dentists across Derbyshire. We have a fairly wide-ranging and widespread service. Those dental practices see about nearly 500,000 people per year. So there is a lot of cover, but it's also very true to say that there is a lot of there is a gap. There's a significant gap. We only have, I think, a handful of practices currently accepting new NHS patients. We've had 7 or so practices hand back their NHS contracts over the last couple of years and instead pivot to seeing only private patients. We have significant areas of dental need, and the need for dentistry really matches deprivation. So we know in areas of high deprivation, the need is significantly worse. And the need is really shocking as well. So in Bolsover, for example, one of our worst areas, we know that nearly a quarter of all children have some kind of dental decay. So that might be 2 to 4 decayed teeth. In one of our more affluent areas, the south of the Derbyshire Dales around Ashbourne, that number drops to 8%. So it's an almost threefold difference between the most and the least needy areas. But those areas of greatest needs are really where we need to, and we have been focusing as much effort as we possibly can. Let me just then talk a bit about what has happened over the last 2 or 3 years. So one of the first and biggest things that's happened is that there has been a contract uplift offered nationally to support dentists to stay in the NHS. So Miriam's just explained about units of dental activity. That's a payment per unit, and that number, that amount was uplifted across the board to try and make the contract attractive and to try and retain staff. And we implemented that in Derbyshire, as everybody did. I think here in Derbyshire, actually, our average rate, because you pay different dentists different amounts, but our average rate is above the national average. So actually, for us, we were already there or thereabouts, but we have made sure that everybody is getting the national expected amount. We have also introduced, again, this was a national programme, introduced something called a Golden Hello, which you'll have heard of perhaps from other areas, where we offer a payment for dentists who join as NHS dentists, and 4 practices have taken that up and are looking to commit to the NHS, and in order to gain the payment, you have to work for at least 3 years. And then the final kind of big structural thing we have done is allowed dentists to go up to 10% over their allocated amount. So this would be we set an annual UDA rate. We say we would like you to hit this kind of target for the number of patients you see and the number of units of dental activity you do, and we are normally, if a practice exceeds, they would stop before they hit their target, or when they hit their target, we have said actually you can exceed the target, and the reason for that is we just want more patients to be seen. So we have allowed dentists to go over their budgets where they can in order to see more patients. Next slide, please. As well as that, we have provided additional funding, and we're focused really on the highest priority patients. So there are, for example, patients in care homes who really have problems accessing and have high need. And this can be really life-changing for people in care homes. It can affect the way they speak and communicate, and it can affect the way they eat and hydrate. So we have really focused some effort with our colleagues in the dental profession to develop and commission a new service to support people in care homes, for example. We've also provided more funding to the community dental service, which is an NHS service which we commission and focuses on children and more vulnerable patients. So these are children and patients who struggle to access, or for whom normal high street dental services haven't got enough capability, really, expertise to deal with their particular needs. So we have funded those that service. We provided that service with more funding. We've also, and we were one of the first counties in the region to do this, commissioned additional urgent dental appointments. So we know that sadly, people struggling to find an NHS dentist have no option often but to try and ring 111 or even go to ED. And we know that out of hours, sorry, not out of hours, but across the board, the number of urgent calls for dental care through to 111 last year was over 37,000 just in Derbyshire. So that's 37,000 people who, some of whom, a great proportion of whom really, needed urgent dental care and were in, we're trying to access it. So we have commissioned more urgent dental appointments, and we'll go on to talk about the continuing work in this area to try and meet that. And then in one of our patches in Bolsover, which I've already mentioned, which is an area for us of really high priority because it has some of the worst dental need, the highest dental need, and it has poor access. They had, I think Bupa were providing dental care there. They withdrew from the contract, and we have recommissioned an NHS dentist in Bolsover. It was a particular and probably quite unique example because actually in that instance, although the dental service left, the dental site was still in place, so the building and the facilities were still there. So we were able to procure a service, an NHS service, to go in and replace to make sure we didn't lose capacity in that area. And that's quite a big job because you have to go out to the market. There are obviously you have to go and get expressions of interest. You have to sort out the contracting, and you have to make sure you've done your due diligence on the provider so that that they're of high quality. So it takes some time, but it's one of the things I think that we feel is actually a real achievement, and it is, I think, a mark of how difficult the situation is at the moment. That just retaining what we have in these areas of need becomes a real priority. Next slide, please. And I think I've mentioned it before already, but I think that if we're not careful, there can be a kind of council of despair, and people can think there is no NHS dental service at all, and that's really not true. As I said, there were over 450,000 unique patients seen, so individual patients were seen. So nearly 500,000 people were seen in the last year, and our population is 1.1 million. But so there were 450,000 patients seen. The actual amount of activity done increased in 24-25 from 23-24, and they saw nearly 4% more. The dentists actually are doing more or less all the work they're asked to do. So 9 out of every 10 appointments, they have the capacity and they're delivering that. And as it says there, they did about 1.4 million units of dental activity to, as I say, about 450,000 different patients. And on average, I think you're seeing an individual patient will have about 3.5 units of dental activity per episode of care. And as we've said, as it says there, the units of dental activity are a whole raft of things. So it could be just the checkup, it could be a filling, a crown, it could be a whole raft of things. Next slide, please. So I think, well, as I've already said, though there is a lot happening and we are doing a lot, and our NHS dental colleagues are doing great work, there is still a significant amount more needed. So the government have a target to commission an additional 700,000 new appointments across the country this year. Our share of that here in Derby and Derbyshire is about 16,300. We've already commissioned about 13,000 of those, and we have firm plans in place to commission the remainder in year. And we want to go further and commission more on top of that. But to some degree, urgent care appointments are just the kind of treating the symptom, not the cause. And what we also want to do is commission additional routine appointments and routine dental care. So more NHS dentists in the areas of highest need. So that's really what we're trying to do as well. And then in those areas of highest need, as I've already mentioned, Bolsover and Amber Valley, but you could also talk about the east of our county and certainly Derby City as areas of really high need. And we're looking to focus our efforts first on those. One of the pieces of work we did last year was something called an oral health needs assessment, which set out in real detail where the need is, and that then gives us the tool so that we can really focus our efforts on commissioning additional capacity and additional services in those areas. Then the final thing we're looking to do here is really focus in on target services for the people who are most in need. So I've already mentioned people in care homes, but also children, particularly in children in deprived areas, also children, for example, in special education, who currently perhaps don't have access to dentistry and aren't suitable for traditional high street or find accessing traditional high street dentistry, even if they can find it, extremely difficult. So those kinds of dental special educational needs is a priority for this year and a national priority. And then we have a whole programme of work which we work on with colleagues in our public health and councils around oral health needs assessment, oral health promotion, and the whole prevention agenda. For example, supporting teams and supporting staff to help people with toothbrushing and to train and educate children and parents in toothbrushing in early years. Next slide, please. I think we may. So that's something there about what we've been doing, what our priorities are, what the picture looks like here in Derby and Derbyshire. I think we have some questions there that we would like to get a sense from you, really, about what your thoughts are on some of this is and what you think we might be able to do better, or we should focus in on. Miriam, do you want to talk us through this?
Yes, thank you, Clive. So on your screen, you can see a QR code. As Mark mentioned earlier, you're very welcome to hover a phone in front of it if you are comfortable using a QR code, and it will bring up the question on screen. You can type in multiple answers, or I have put a link in the chat box. Now, when we ask this question, very obvious answer. Oh, cost has come up. Great. Very obvious answer is access, and that's absolutely fine if that's your answer, or just generally being able to try and find one. But some things that we're also hearing, like what's coming up on screen, is things like transport and general knowledge. Actually, do people know about the Find a Dentist app? Find a Dentist website, sorry. So this is really interesting. Thank you very much, everyone. I was sort of semi-concerned that I was just going to get one big access word on the screen and then that would be it. So this is really interesting. We're seeing, literacy, health, time, cost, transport. Multiple people are saying transport. So the bigger the word, the more people that have put that or something linked to that. So that's really helpful to see. Supply not meeting the growing demand. Not being able to find someone local, mistrust of services. Yeah. Dentists just generally not taking NHS patients. Fear, that's something that I've heard a few times. Fear of the treatment, is it going to hurt? I've been ignoring this niggling pain and now I don't want to go because I feel like the treatment's going to hurt. Or fear of cost, how much is it going to cost me? So I'll keep putting that off.
It looks like, doesn't it? I think the Slido is perhaps the word cloud is a little hard to interpret, because actually when you look at the number of comments, the main one that comes up again and again is the one you would expect: dentists not taking NHS treatment, not taking NHS patients, which is what we know. As I say, I think when I last checked, there were only 4 practices actively taking NHS patients at the moment. It may have changed slightly, but I don't think it will have unfortunately risen much higher than that. So I think that is the main issue. I think, as I say, that belies the fact that actually there are a significant number of people who are already able to access dentistry, NHS dentistry, because we can see the numbers and actually the activity is rising. But clearly, it is a problem if you're trying now to access an NHS dentist. So yeah, I think we're seeing that, aren't we?
Yeah. Yeah, it's interesting. Thank you. Thank you everyone for interacting. I should have said as well, during these Slido questions, there's just 2 more. If anyone does have any issue with the QR code or the links that I'm putting in the chat, feel free to just write something in the chat box and I can enter it for you, or I will definitely be capturing people's feedback. So thank you. Right, I'll stop that one for now then, and I'll move on to the next one. Someone's already put in this one, in the first one, bad experience. So the next 2 questions are to gain some patient experience. So thinking about yourself or thinking about what you've heard from a friend, a colleague, a family member, maybe actually trying to sort out a relative or child themselves. Is there anything positive? What went well on your last dental visit? The next one does ask what didn't go so well. It's very important either way for us to capture that information, but I thought I'd just start off with the positive one first, if there is anything that people want to share. Did anything go well last time you managed to visit a dentist, or last time a relative or someone that you supported to see a dentist?
Oh, saying that the
Oh,
poll
I'm
isn't
very
active yet.
sorry. Oh, apologies. It should be working now. I've put the link in the chat again, and the QR code is up on the screen. Thank you. Brilliant. And there's a couple of things coming through on the chat as well. Thank you. Yes, Jonathan, thank you. NHS, if you were seen as an NHS patient, I think that would be the best. Friendly dentist, lovely. Detailed explanation of the treatment. That's really good. Excellent care from the hygienist, that's good. It's all the staff, isn't it? It's as soon as you walk in, you know, the reception staff, the hygienist, the dentist themselves. Good manner with a child, that's brilliant. So private experience, yeah. They were, yeah, brilliant. I suppose that's just as important. Saw the whole family together, that's really good. Efficient use of your time, getting you all in. No treatment plan given to explain cost, okay. Quick. Brilliant. Yeah, that's brilliant. Making the next appointment before you leave, because it's one of those things, isn't it? When you're told, you know, maybe it's routine, follow up in 6 months or a year, and then you completely forget, don't you, once you've walked out the door, or you can't get back in again. That can be a problem as well. So that's brilliant to be booked straight back in again. Yeah, clear information options given for care. Brilliant. Give people a few more minutes. It looks like there's some typing. Brilliant. Clear information options given. Quick made appointment. Yeah, brilliant. Oh, had to push to get the fluoride varnish. Right, okay. Oh, thank you, Michelle, and comment in the chat. Very friendly, helpful receptionist, great dentist, regular checkups. That's brilliant.
It's nice to see you, Miriam.
Oh, thanks, Michelle. It's lovely to see you as well. I recognised your name.
Oh, yeah, I recognised yours too.
It's lovely to be back on. Thank you. That's brilliant. So I'll stop that one and move to the next one then. So our final one. And I'll just put the link in the chat for people. Brilliant, and that should be active. So yeah, so this is you know, what didn't go so well. It's important for us to know if there was anything in particular that didn't go well, that might prevent you from then returning to the dentist. We're currently paying for private treatment, which costs over £70 a month for 2 people. Oh gosh, 10% increase from the previous year. It's not affordable in the long term. No, private plans can be costly. No NHS access to hygienist when requested for a 15-year-old. Oh gosh. Yeah. quite a few people typing, so I'll just give it a few minutes. Thank you.
James, Lisa, I wonder whether after this it might be worth us highlighting, what the evidence base around what the NHS provides, if we know this in terms of dental care. We know it, but if we know the detail of this, and why, because it's true, isn't it, that the NHS doesn't provide all of the services you might get privately. Some of that is because of the evidence base. So we wouldn't necessarily, as a provide that service to the whole population routinely because the evidence base isn't strong. Doesn't mean it isn't a good service and that you wouldn't want it, maybe, or you wouldn't. People don't buy it privately. It's just not something we commission on the NHS. So I think that might be something worth exploring or explaining if we've got it. I think the other thing we could probably talk about is the kind of national work on the national contract. The NHS dental contract hasn't been updated since I think 2000 hasn't been substantial. Was first developed in 2006 and hasn't been substantially upgraded since then. So it might be worth that, and that is work that's ongoing. And there is talk of a new NHS contract, which will perhaps change how we contract and what we can commission. And I wonder if it's worth us just updating people on that as well.
Yeah, thank you, Clive. I just want to reassure people that all the feedback that we're getting through this Slido, I am capturing. I can pick all of this up, so it doesn't just come on the screen and then disappear. This is all something that we are very grateful to receive. And as part of this Derbyshire Dialogue session, I know any questions that we get asked that we can't answer here, we do feed back to people, I think, via the engagement platform. So some of these points that are coming up, it would be helpful for us to be able to respond to people. So please do check the engagement platform after this session so that we have opportunity to feed back to people on some of these points. James has also helpfully put a link in the chat directing people to the NHS website that says
perfect,
what services are commissioned for the NHS. So that's really helpful as well.
Thanks, James. That's perfect. That's exactly what we needed.
Yeah, thank you. So yeah, there's a lot there about people receiving private treatment and the cost, length on waiting lists. So yeah, it'd be helpful for us to be able to come back to people on some of these points and give an update.
Yes, I think that's it. I think that's the other thing, is that perhaps it's a misconception that people you might normally naturally assume that NHS dental cost means that it's entirely free, just as NHS general practice medical services are. But of course, it's a co-payment approach, isn't it? So, and that can and does tot up as well. So, yeah, that's perhaps more communication than anything that we can really do locally.
Yeah, thank you, Clive. I'll leave that last one open just in case anyone is still wanting to feed into that. I'll leave it open for a few minutes, but I think we can move on to the next slide. Thank you everyone so much for participating in that. Whenever you do like engagement in sessions like this, you always worry that no one's going to actually give you any answers, but that was so helpful. So thank you.
Yeah, so this is, I think I've got ahead of myself, haven't I, previously? But I think, yeah, I mean, effectively, here in Derby and Derbyshire, we've got three big priorities. One, and I would probably say them in slightly in reverse, in a slightly different order than this, but they're all here. I think our first priority is NHS dentistry in areas of highest need, routinely, recurrently. So establish more NHS dental provision where we need it for ordinary routine care. Because if we can do that, then some of the other problems we can see around urgent care access and access for children and all of those other problems we've got will be sorted. It'll be addressing the problem at its root. So I think that we've got it here as number 3, but for us, I think it is probably our top priority. And that is about us commissioning more activity, commissioning it differently, looking at how much we're paying in what areas so that we can make sure that we are commissioning at an attractive rate and a rate and in a way that rewards the work. One of the issues I think we've got linked to this is the process at the moment is quite bean county. The national contract is quite bean county. You do it on units, and dentists report back to us that makes it feel like we are on an absolute conveyor belt, and we are rewarded for doing activity, but we're not rewarded, or it's not. It doesn't recognise that the more complicated the patient, the harder that work is. So it effectively incentivizes us to do work quickly, and ideally for patients who are perhaps less complex. That's just the way the contract kind of incentivizes you. So we're keen to look at, well, are there ways that we can incentivize and support dentists to do perhaps more complex work for people who need it more, and provide that same high quality, but in a different way. So that's the first thing, the routine. The second, I think, and it's urgent, is the urgent capacity. So as it says there, we've commissioned an additional 16,300 care appointments. We think we need to go further than that. We know the demand is high. So at least whilst we're getting this routine, we're increasing the routine capacity, we will need to commission more urgent care capacity. What we've also done here in Derbyshire is, as well as just that one urgent care appointment, we've offered additional urgent appointments for people. So you go to the dentist with urgent pain, you have that treatment. What we could have done, and what the kind of national target is, one appointment per person effectively. But we don't want to do that because we think that won't be enough. So we have, on top of that, commissioned what we're calling stabilisation appointments. So a couple of follow-up appointments if you need them, to make sure that not only is your urgent problem sorted, but you've got hopefully the root cause addressed. And then finally, as I've mentioned, there are particular groups of people who I think we're particularly worried about, and I've already talked about those. So I think we're going to do some really targeted work to try and identify those groups, those individual people with their specific problems, and those cohorts of patients, and really target some more specific services at them. I think is that us for the slides, or is there one more slide left?
Yeah, there's a couple more.
Oh yes, look. So I think that the dental checks and special educational needs setting I've already mentioned. It's a national priority, but it's a local aim for us as well. And then I think the other thing, that fifth one there is this, as well as all of this, of course, there's a whole set of things that, despite that we have to do, we call them business as usual. So there's a whole raft of services that we have to continue to provide, commission, and when those contracts run out, we have to recommission. There's procurement law, which means that we have to go back out to the market from time to time to test the market and go out to another procurement. So there's a whole raft of work that James and Lisa and the team do just day to day to continue to update, recommission, commission, procure services, and there's a list here, and it is mundane things like clinical waste. So you don't think about these things, do you? But we have to commission a service to make sure that waste is managed, and that's a big regional commissioning procurement approach, which takes time and effort. We're commissioning it this year, in fact. But it's just that day-to-day work is ongoing and is always will be work that we do. I think that have we got more priorities on this slide deck, or no? Okay, thank you. Miriam, did you want to just talk us through this? This was just some advice, I suppose some key messages, aren't there, for people?
That's right. Yeah. So this slide and the next one is just a sort of message to take away. So many people on this call may already know, but it's a bit of a, can you spread the message? People need to know that they can access 111 if they need urgent dental treatment. They can also access 111 if they need out of hours dental treatment. And 111 can also offer people advice if they are in pain. What we really want to do is try and stop people from having to present at their GP or especially A&E. So it's just really that message that also for dental treatment, as well as all other health conditions, try and think 111 first. So it's just a little key message to spread with your family and friends, please. And then the next slide. So how are we planning on keep people informed? So there's a couple of links on here for you. Again, a lot of people on this call will already be signed up to the Joined Up Care Derbyshire newsletter. We've given a couple of dental updates over the last couple of months, and I'm sure we'll be working with our comms colleagues in the ICB to provide more dental updates in the newsletter. So if you're interested, you can keep an eye out in there. We're also working with our comms team to update our website. I've linked it there, but give us a week or two and it'll be all revamped and there'll be new links and new information. So like we were talking about before, there's going to be some information about how to access for general, how to access for urgent, the cost bandings, you know, who's eligible for what, that kind of thing. So hopefully it's going to be really clear and really informative. We're also looking at engagement. So how do we engage with our population? As an ICB, we're always engaging with people who have poor access to health services. So we're very early stages in a new engagement dental plan. And we're working with lots of organisations like the local authority to map that out and see, you know, what areas we need to target specifically across Derby and Derbyshire. We're also organising a part 2, what we call a dental summit. So we met with lots of colleagues at the end of last year. So it was the ICB, it was the East Midlands team, it was local authority council colleagues, organisations like Health Watch and Public Health. And we're meeting again at the end of this summer. We're hoping to plan that in for September time. So that we can really look at our priorities that we've shared today and make sure that we're all keeping on track and working together to deliver those. So we can also update on that. So thank you very much for having us. I think we're moving over to the Q&A part of the session. Oh yes, and contact details at the end. Thank you.
Right, thank you very much for that. So what I'll do is I'll run this bit, Miri, and read out any questions and make sure we capture them. So the first question, it's there are sort of 2 parts to the same issue, and it's from Jonathan. He asks, is there any information about how many people, especially children, have access to a registered dentist in the most deprived communities that already have the worst health inequalities? Jonathan notes that the oral health needs assessment that Bolsover had the highest level of dental decay in 5-year-olds, and you've also highlighted that as having the poor access, those 5-year-olds. Are there any levers to enable progress on getting dentists to the more deprived areas?
Shall I just... I was going to say, James, you're going to come in on this.
Yeah, no worries. So for the first part, yeah, so we've been working with NHS England dental public health colleagues who are specialists. They're dentists as well as public health. And we've really been doing a lot of work on the data because it's something that hasn't been as strong previously as it is now. Obviously, there's some complications in terms of not being registered, so we have to use the data that we have. But we've got a lot more data, particularly on children in terms of tooth decay and stuff. We pulled that from National as well, so there's a very recent publication just come out with the latest updates around that. But obviously, we're looking all ages because it's not just children that are vulnerable populations. So looking at things such as head and neck cancer rates, as much data as we possibly can to understand where we need to put that activity. So yeah, we've coming out of the oral health needs assessment, that's kind of really strengthened that in terms of that data that we're collecting. Without going into too much detail, we group it in an area that's smaller than a postcode, but bigger than a street, so that we can get kind of granular detail of the communities that need our help without broad brushing across, well, that part of that town's fine because it's that postcode area, which can be quite broad. The second part, are the levers to enable progress in dentists to more deprived areas. Yeah, I mean, as Clive said, we're focusing investment on deprived areas. We have to make a balancing act on that because we don't want to do that to the detriment of where there is care providers there, because we don't just want to say, well, we'll stick it over here because it's a deprived area, whereas this one over here is equally important. So that is a balancing act. All of this is caveated by some of the things that are outside of our control. So the contract reform that Clive was saying earlier, that's absolutely key in order to make that happen, because the UDA system is quite outdated now and doesn't support this. And the one that kind of jumps out, the elephant in the room, is workforce. So there's been huge amounts of work going on nationally around workforce, around getting more dentists into the system. The feedback we've started getting from that is that it's improving. It's not as bad as it was, and we're starting to see that in terms of the amount of activity delivered. But we have to obviously work within our means. So we do invest. The levers we have are what we are. So, for example, the Golden Hellos, we targeted those to those deprived areas. That was one of the key metrics of weightings that we put it to. But ultimately, we can't just go and grab a dentist and say, you're going to work there, thank you very much, because obviously they're private people working for private businesses at the end of the day. So I hope that answers, but if anyone's got anything to add, then.
If I could just come in, James, I know we have got, as you said, information on lead, which Jonathan's already referenced. Do we have information about who is registered with an NHS dentist, and to what degree? I don't think we have that.
They're not registered, so it wouldn't come across as they're registered there, so we wouldn't have the data.
Okay.
We do know the number of people who are accessing a dentist in that area, and how far away the nearest NHS dentist is from that area. But it would be impossible for us to know how many are registered, because they wouldn't keep that as a list.
Okay, Lisa, I'll let you come in, because the only thing I was just going to add as well into that what could we do? As you say, it's a nationally driven contract, but there is that some local flexibility, isn't there, about what we can do, and the kinds of things we're looking at are, as I mentioned already, moving away from a unit of dental activity to a sessional rate to try and encourage, to make it easier for dentists to spend more time and get paid to spend more time with more needy people, because the unit of dental activity approach, as I mentioned before, works best really for people who haven't got that much complexity, and it's not so good in areas of high need where people don't have much access and perhaps have great dental decay. We're also looking at longer contracts, so looking to establish longer contracts to give dentists that stability. And as I mentioned also, we're looking to see if we can increase the amount of money we spend, the unit of dental activity rate, to reflect the need of the area. So in an ideal world, if you weren't paying on a sessional rate, the more needy your population, the higher your unit of dental activity should be, and that isn't always the case. So we're trying to correct that as we progress. Lisa, you had your hand up. I'm sure you were going to say something really informed there.
I was going to say, James beat me to it really. Just to say that we do have access to attendance and reattendance rates for a particular provider in a particular MSOA area, so we can provide that. But as I say, as James said, it's work that's been undertaken, the oral health needs assessment, which we're doing at present really. So sorry.
Okay, I think we can move on to the next question. Julie has asked, how do 111 know who has additional capacity for urgent care?
So through the work that we've been doing from the procurements that we talked about earlier, we went out to all providers to see who wanted to provide the service, essentially through two different means. That work's now concluded, so we have the list of providers, and like Clive said earlier, Derbyshire actually did this sooner than a lot of other areas, knowing what was coming, and kind of got ahead of the game in that sense. So we work with 111. We speak to them on at least kind of twice weekly basis to say these are the providers, without going into unnecessary complexity. They have direct links through between the dental providers and 111, so that they can make sure that when the patients are coming through, they know which patient it is, and sort of they've been through that process through 111. As people join, we can add them onto that list really quickly, depending when they're ready to mobilise. So they have the list provided essentially of who it is, where they are.
And James, am I right in thinking that the plan at the moment, people are directed to the right providers, aren't they, through 111? But the idea ideally would be that people at 111 can book people in directly, but we're not quite there yet in terms of the link up.
Yeah, so the patient will be told where they're going, so the dental provider will be aware. But the idea is it'll be a much simpler process. They literally book them into the slot, but we're still working on that. But everyone will know that the provider will be expecting the patient, and we'll have that information ready when they arrive, essentially.
Excellent. There's something in the chat from Helen. I'm not sure if it's a comment or a question. Helen, would you like to tell us if it's a comment or a question?
It was a comment really, just to about the future comms of the how to use 111 for urgent care. Just to obviously the Oral Health Steering Group, as you know, Clive, link up with Public Health and DCC for social media comms. So like the sooner we can get that information out through social media and public health, I think, about how to access urgent care, the better really. I know you're working on the website pages, so hopefully there'll be stuff that we can lift off there. But I'm sure there's a lot of people on this call that'll be anxious to get that out as soon as possible, really. And also that positive news about the up to 2 follow-ups as well after that urgent appointment, which we're doing in Derbyshire. I think that's to be really celebrated. So I think awareness for the public that if they're not already attending an NHS dentist, that is a possibility. If the dentist deems that suitable, then I think that's really positive news to be given on that same comms message as well, if that's okay.
Yeah, absolutely. And I know, as you say, the team are working on the comms, aren't they? So, but you're absolutely right.
Thanks.
Brilliant. We have another question in the chat from Cheryl. Cheryl wants to know who is providing dental checks in special schools.
James, did you want to come in?
We don't know yet. So we'll be doing it as a kind of procured activity, like we mentioned earlier. So different providers will have the option to come forward for it. So until the works commission, we don't know who's going to be providing it as yet.
And I think it is just generally when I started working here, working on this in this area, it came as a bit of a surprise to me. The fact how much procurement has to happen, because effectively the dentists are all separate independent businesses. If you are going to, and the dental providers ditto, if you're going to try and get a new service, you have to take it to the market overall, which is understandable, of course, and necessary, but it also adds complexity to the whole process. So you can't, with the NHS normally you've got a much more direct route to getting a service set up. This one you have to go through the market.
Okay. Cheryl speaking. Thanks for that. As an oral health promotion team, we obviously support the 10 special schools within Derbyshire. So it'd be really great to actually work together once that's in place, please, because obviously we run a fantastic award for the special schools on oral health, which is, from bronze to platinum. And it would be marvellous to actually know who that person or contracted person would be at the final stages, and just work together, because I think it's important to join up, isn't it? And obviously previous times it was the community dental service. Obviously that's not, I believe, is not in their contract anymore to do that. Is that right? So obviously that would be great news to hear the special schools, because they do ask. And yeah, lovely. Thank you very much for that. Be great to hear from you again.
Okay, just quick one in the chat in case anybody's not looking at it. That Martin has said there's good news in the Bolsover data from the latest 5-year-old survey, which shows improvement for Bolsover, which is great news, and we've discussed Bolsover a couple of times today. We have a hand up, and that is Julie. Would you like to ask a question?
Thank you. It's just a comment on Helen's comment about the comms around urgent dental care. I think it's really important. I used to be a dental nurse advisor at 111, so I know how the system works. And it's quite a frustrating system when you've got lots of people wanting dental access urgently and not enough providers, as there was at the time. It's important, I think, that the public know that there are no 24-hour dental services, so that will be an open, honest and transparent. They will get care advice, but if somebody bumps their head and knocks a tooth out at 2 a.m, although the service is there to give the care advice, they will not find an NHS dentist at those times. I think it's really important to get that message across. So that was my first point. And my second point relates to my colleague Cheryl, who's part of our oral health promotion team, asking about the special care surveys. If you pick up a whole cohort of children with a dental need, how are we going to treat that dental need if these children aren't registered? Does that not create a safeguarding risk? Who's picking up that work?
Sorry, I'm not entirely I sure I understand the question, but
if
we can
you're
say
doing a dental survey and
we'll
you go in
find
and you've got a cohort
The
of
follow-up.
children and 10 of those children have got decayed, missing or filled teeth or need a dentist, will they be picked up by these urgent care appointments, or how will that need be met if you've identified several children in one setting with a dental need and then you've got nowhere to send them to? How is that picked up? What's the process around that? Do we know that?
I think, did Lisa comment? Lisa, did you have an answer? Somebody?
Nicholas, because that's who you're looking at.
Sorry, yeah, I was just going to say it really is very early days yet, Julie. So as James said, it is being picked up within the team, but we've got to have that understanding yet. We've got to have some meetings about it. But we'll certainly link in with yourself and Cheryl. I've made a note of the point that Cheryl's noted down as well, and we'll pick up with you. That's okay.
It's brilliant. Thank you, Nicola.
Thank you. We have another hand up. Nicola Milner.
Sorry, it's just a feedback, Julie, that having read quite a lot of that tendering document for those SEND schools, because obviously we had a vested interest in reading that, it did look like those children were going to be paired up with whoever tendered for that particular school would then take them on to see them for treatment that they needed. So whilst the actual procurement hasn't gone live, there are actually quite a lot of national documents that have been produced for that. And that seemed to be the way that it was heading, that the team who were going in not only did the checkup, but then you took them back to your practice to do the treatment. And I guess if you couldn't, that would involve community dental services and things like that. But it looks like potentially that's the model that they're looking at.
Excellent. Are there any other questions? There's nothing more in the chat. Does anybody have a question to fit in just before the end in the last minute?
I don't have a question, but just to make a final point on that, I think it's really important as well to note that it's really good if we find that demand, because otherwise it was unmet need, which is the worst thing if we've got, because that decay would be there anyway if we knew it was there or not.
Yeah.
So if we're identifying it, I'd rather have the headache of making sure that a commission service then supports that child than them just continuing to suffer. So I think it's a positive, awful thing to find in that sense.
And we have a hand up from Colin.
Yeah, it's just a question really about finance, because obviously everything nowadays is down to what funds are available for particular services. Do the ICB feel they're getting enough funding from the government to allow them to be able to attract more dentists, to accept contracts, etc., or is that not the case?
I think unusually, I would say yes, we do have enough. And if our problem at the moment is we haven't got enough dentists, NHS dentists. So it may be that, so at the moment, I think I would say, yeah, we think there's enough money. We just need to spend it. And we need to commission the services. And the government are clear that the money that we get for dentistry is ring-fenced for dentistry, so it can't be spent on anything else. And if we don't spend it on that, then it goes back to the government. So it's in our interest, and obviously in Derbyshire's interest for us to use all of that money. I think the challenge and the pushback to the government, and this isn't this government particularly, but to governments over the last couple of decades, is the contract needs updating. The contract needs renewing, and they need to address some of the structural issues in the contract because it hasn't been substantially renewed since 2006. But to be fair, there are plans that go beyond this administration, past this administration, before this administration. So I think there are plans to update that. So it's not a positive, it's not an optimistic picture really, but I am fairly optimistic that we will see that new contract, and that will then allow us to use this money that we have and that we're not currently spending to meet the demand.
Yeah, thank you.
Excellent. What we'll do is we've come right up to the hour. This has been perfectly weighted, so thank you very much for that. There is one other question in the chat. Hang on a second. Okay, I'll ask this. Well, if you're okay, Clive.
Yeah, no. Well, I think if that's Ricky, Ruparelia, yes, I think that's absolutely. I mean, that's the procurement process.
So the question is, just for the recording. Ricky has asked, are the ICB open to having new providers, or is the additional funding only available for existing providers? And Ricky is a dentist and willing to become a provider, but has been struggling to get any response from emails to the ICBs.
Well, we can pick that up outside of the meeting, but the answer would be yes, of course. It's an open. The procurement processes we run are open and transparent, and as they have to be. But yeah, we will pick that up. James, you put your hand up there. Did you have anything specific?
No, I just know that previously we've confirmed that we'd have to go out for an open procurement process, so we couldn't just say to someone, "Here is the money, go and open." It would be, we're looking for a provider in this area, so it would be through that process on Find a Contract on the government website.
Okay, we'll definitely bring it to an end there. However, if anybody on the call today or listening to the recording after today has any questions whatsoever, please raise them to me at ddicb.engagement@nhs.net, and I'll forward those to whoever needs to receive them, and we will provide you with an answer. So in closing, that was a great presentation. Thank you very much. Tons of useful information, and it looks like we're heading in the right direction. Maybe not quite there yet, but we're moving there. So thank you very much to the presenters, Clive Newman and Miriam Doherty, and also to James Barsby, who was quite instrumental in a lot of the answers as well. The biggest thanks, of course, are to the audience. Thank you very much for turning up today. We put on these sessions for you, so we're very grateful for your presence. And if you have any ideas of anything which you really want to hear in the future, then again, put them to that email address and we'll see what we can do for you. Look forward to the next session, which is on the 16th of July, and that is on the subject of improving women's health. So very specific there, but that doesn't mean that it's only a women-centric topic. Everybody needs to know about this, so please do tune in. This session will be uploaded to YouTube later today, and as soon as that's done, I'll also send out an invite to the next session. So thank you very much for today.
Thank you.
Thanks, everyone.
Thank you all.